tough to go late in the day. I think everyone has already said better what I was intending to say, so I'll go through my slides and try to reflect on some of what I've heard earlier too. And so, I come to talk to you about what's going on in the U.S. In a spirit of humility, not because you should do what we do, because you really couldn't set up a more complicated system than ours, but because there is often a lot to be learned from failure, and there's certainly a lot to be learned from experimentation. And so I'm very happy to be learning so much from the excellent work that's going on here. And the other thing, as John mentioned, I'm an economist, and I study payment systems. So that's what I'll be talking about today. But just because I study them doesn't mean I think that they're the solution to everything. I have come to the conclusion after about 25 years of studying payment systems in the US that it is absolutely true that payment systems can prevent providers, clinicians, patients, the system from doing the right thing. It's very hard to fine-tune a payment system to achieve a set of results. But I do think part of the job with payment reform is really getting the payment system out of the way. When Andreas was talking about his individual cases and said, you can't do something from, in our case, Washington, that's going to fix that problem. But you can do things that make it next to impossible to implement a low-cost, high-quality solution to take care of that COPD patient in rural Alberta or rural America. And I think that's probably the challenge we should focus on when we think about payment reform. So just to define terms, in the U.S. we use the term value-based purchasing to really include many different ways that public and private payers contract with providers to accomplish value in healthcare, and just thinking here as an economist, I think of benefits net of costs as opposed to the ratio of them. But in any event, payers may use, for example, selective contracting. This is an appropriate way to think about value-based purchasing, perhaps in a market-based system like ours. Probably not so much in a system like yours, as well as performance measurement, reporting, and payment systems. But then we also think about these holistic payment reforms, as you've heard about today, as being part of this portfolio, even when they're not, strictly speaking, engineered around value. I would say a lump sum payment to care for a population with no quality measures isn't really value-based purchasing, although it might, in fact, increase value. We have many different payers in the U.S., and at least today, perhaps not tomorrow, Medicaid is actually now the biggest chunk of our public system. But Medicare has traditionally really, because Medicaid is actually 50 different programs and not one, and because Medicare has historically been the largest dollar spend in healthcare, it has really, when we think about payment reform in the US, we're mostly talking about Medicare, but also commercial payers. But commercial payers tend to need to align with Medicare because otherwise it's very hard for them to accomplish their goals because of the mixed signals that providers are getting. Medicare has implemented value-based purchasing over the last 20-some years for hospitals, for private health insurance plans that deliver Medicare Advantage. I won't talk about those. But also now, more recently, for something we call health systems, which probably is not the same thing as what you call health systems. And it may include real health systems that are organized as health systems, but also providers who choose to come together to share accountability with very loose types of governance. And then, of course, physician payment systems as well. So the current approach in the U.S. Is really, I think of it strategically, it's a two-pronged approach. On the one hand, Medicare has offered, starting with the ACO shared savings arrangements and going forth from there, has offered a set of new alternative payment models, which is getting out of the existing system to some extent, although some of these models are also transitional in nature, but new alternative payment models that that providers can choose to belong to. And then they have continued to reform and add to the existing payment systems for physicians and hospitals. I think it's, to me at least, it's evident that the reforms around the existing systems are in part about changing the behavior of physicians and hospitals subject to those systems, and in part about making the status quo less and less appealing. Because if you have an opt-in system, you're going to get sort of minimal traction if the status quo seems okay. And the status quo in particular has been pretty good for those who make a living delivering procedures, who are getting paid pretty well on the physician fee schedule. And so, why should they ever want to join an ACO? But I'll tell you about the merit-based incentive payment system, and you'll start to think joining an ACO sounds pretty good. So this is stolen from Bob Berenson from a paper he and colleagues developed. Just to give you a little picture, I sort of like it first to convey, at least for us, we have quite a lot of variety in the payment system. So the way these charts work is it's really just the vertical axis there is sort of payment systems moving away from sort of widget-based, narrow accountability to broader scope of accountability, more integration of care, and more intensive accountability. So, at the lower end there, that big orb where we are today is fee-for-service and siloed payment systems in the acute and post-acute settings. And then as we move to the right, again, in the current state, we do have providers accepting more accountability with quality incentives initially, and then with sort of low-level alternative payment models. That would be something like shared savings, where we're still paying fee-for-service, but you can recoup some of what you generate in savings, all the way up to global payment models that are fully prospective, that is a predetermined budget for a pre-identified population. And although I think that they're sort of generous in their far-right bubble. And in the future state, we imagine that the world will shift, but it won't shift in a wholesale way. There'll still be a little, I don't know whose future this is, but a very little bubble of fee-for-service. And for those who are effectively willing to take fee cuts in order to avoid everything else. So, as we project the current set of reforms, if you're a physician and you choose not to report quality and you don't belong to a system that can do it for you, and basically you choose to stay in the historic system, then you will get something like a 10% fee cut, and presumably it will get worse. So that's sort of, what we're thinking about, an evolution, but also an evolution that leaves variation. So to start with these these alternative payment models, accountable care organizations are really the one that we talk most about in the policy world in the US, because it has the potential to be the most disruptive or different from the way care is delivered today in the US. At its heart, an accountable care organization is an attempt to offer a flexible alternative to the existing integrated models that you've heard about in the US now. So it's really a delivery model that has the capacity to be accountable for a population through a variety of mechanisms. So it's both a payment system, but also a delivery system that isn't necessarily sort of all under one roof in terms of legal entity, but there is some governance structure that glues together a set of providers who can deliver the vast majority of care that a population of Medicare patients need. At the sort of entry level, these systems can share savings over a narrow band relative to an actuarial prediction of their costs. So you can imagine that prediction is really important, right? So if you're in a place where the expected costs are much higher, and perhaps your historic costs as a result were much higher, or as they're higher in the other direction, then you have much more bandwidth for generating shared savings. If you're already in a place like Rochester, Minnesota, where the costs are already low, and you're given an actuarial projection, it may be much harder to hit that kind of target. And so these accountable care organizations, there are a couple of different flavors that are being experimented with in addition to the Medicare Shared Savings Program, which was implemented with the Affordable Care Act. And providers can opt in if they can meet certain requirements. I'll tell you a little bit about the emerging evidence about the success of these programs in Medicare, but I think the tension here is this model really tried to be flexible enough and soft enough that there would be high levels of participation, and yet it's not clear that those sort of soft and flexible models will ultimately be effective, and that makes it challenging to know whether this is a good idea and we just need to hold tight if the evidence comes in null, or that even in its extension we won't be successful with this. But ACOs have grown over time, and we're now in close to 800 ACOs in the U.S. Still a minority of patients, I believe something like 15% of Medicare patients are being touched by an ACO or cared for in an ACO now. But still, in fact, if you read some of the general news about ACOs, there's been a lot of concern about ACOs sort of entering in 2011, 12, and then exiting, and the idea that that was evidence that this is a failed idea. I don't think if you were going to take that measure, this chart would endorse that for you. But there have been health systems that have tried this and not done well and chosen to get out of it. And I think we have a lot to learn from those data as well as from the performance of those that have stayed in. So then just to go back to bundled payments, which you heard about from Rob, this is another alternative payment model, and there are a variety of these, the goal of which is, again, to extend accountability beyond the single provider, single point in time, visit-based or admission-based accountability that we have in our current systems, and thereby to encourage coordination, collaboration, but also getting providers to think more holistically about what patients need. And I think these were also opt-in systems, and not only could hospitals and physicians together opt in to a bundled payment system under Medicare, they could choose for what kinds of services. So, of course, you would expect that providers that have the sophistication to do the data analysis that you saw from Mayo Clinic, which is really a minority. There are very few providers who can actually determine whether they can be successful under bundle payment. So it's those that can actually do the math and come up with a bundle amount that they can be successful with that will come forward. And they will do it where they're going to make money and minimize risk. And so Medicare has gone on to implement bundle payment for all providers in certain geographic areas for joint replacements, and is continuing to study bundle payment for cancer care as well, which I think is an interesting area. But just anecdotally, hearing from some participants of these experiments, particularly for conditions like heart failure with very substantial post-acute care costs, that accepting bundle payment with the 90-day window for post-acute care has forced hospitals to figure out where their patients are going when they're discharged, and what is the quality of that post-acute care. I think if nothing else, that seems like a really good idea, that hospitals should know where patients are being discharged and preferentially refer their patients to post-acute care with post-acute care facilities and providers that have low readmission rates, that have demonstrated high-quality care. So, while those alternative payment models are out there for providers to opt into, Medicare has implemented a whole host of incentives for hospitals first, and then later physicians. Hospital value-based purchasing really goes back many years, but the most recent sets of programs have included pay-for-performance for hospitals that addresses now a comprehensive set of quality measures, patient experience, outcome measures, and cost per beneficiary. So there's sort of a balanced scorecard approach, and as of fiscal 2017, a 2% bonus or penalty under those value-based purchasing programs. And then on top of that, there are penalties related to readmission rates and penalties related to hospital-acquired conditions. Some of these programs are fairly controversial. I would say at the top of the list, there's a lot of concern that all of these programs disproportionately penalize providers serving low socioeconomic status patients and patients with other social risk factors. And I was just on an Institute of Medicine committee that developed a set of recommendations for CMS to consider using some specific approaches to account for these social risk factors. So these programs have really raised the bar in terms of what kind of data hospitals have to collect and report. It's all publicly reported on CMS's website. If you have a loved one who goes to the hospital in the US, you can quickly look up all of their data on that website. So they're there for patients. And they do have pretty substantial financial implications for hospitals. These percentage points are low, but for those of you who work in healthcare, you know hospital budgets are big and margins are really small. And so a couple percent here and there on your Medicare revenues makes a huge difference. So physician payment reform has been much slower going. Physicians, there was a reform that was put into place in the 1990s that really, I think most people feel, most experts feel, has not done much good to the delivery of physician services in the US. Our Medicare fee schedule overemphasizes new technologies just by the nature of the fee schedule, and so the incomes of those who deliver procedures and things that tend to evolve technologically have grown rapidly, while the incomes of physicians who deliver things where there's not a lot of technical change, so cognitive-based care, their incomes have stagnated, and there was a cost control mechanism that was layered on top of the fee schedule called the sustainable growth rate, which essentially intended to tune down the fee schedule growth at any point at which total Medicare spending exceeded a benchmark. But this very crude methodology essentially would have reduced primary care payment because there was too much robotic surgery, and it would have required fee cuts, which are not terribly popular in Congress. And so Congress basically, every year that they were supposed to do fee cuts, they declined to do so. They pushed it off until essentially they were supposed to put something like a 20% physician fee cut into the next budget, and there was a big negotiation that resulted in the merit-based incentive payment system, which it was actually a remarkable political accomplishment. Whether or not it's a remarkable health economic accomplishment, I'm not sure. But the merit-based incentive payment system essentially does away with the sustainable growth rate and introduces a pay-for-performance program that will ultimately, again, have this balanced scorecard of quality, advancing care information, which is related to both the process and outcomes associated with health information technology, participation in clinical practice improvement activities, and resource use, which is a polite way of saying cost. So, by 2020, these incentives will drive physician payment up or down 9%. So that's a pretty big risk corridor. The thing about the merit-based incentive payment system, which may lead to interesting results, it's not clear what will happen, is that there's an entire menu of measures that providers, and so a provider could be an individual physician, but if you bill as a group, it's at the group level, it could be at a system level. Providers can choose the quality measures they want to be held accountable for. And there's a menu, but this seems really problematic from a lot of perspectives. Again, all of this choice should drive us sort of to the lowest common denominator, but also makes it really hard to say, let's do a regional quality improvement activity. Since we're all working on these heart failure measures, we could do something collaboratively, but if you're looking at the measure that you think you can do well on and I'm looking at a different measure, I think that makes it very hard to think about such quality improvement collaboration population at a geographic level. So that is being implemented. So what do we know about whether any of these payment system changes are going to move us in the right direction? There's a lot of evidence outside the U.S., and in some cases it's hard to extrapolate. In other cases, I find it very useful. So this is a slide I have stolen from Yasmin Kantarovich, who very generously guest lectured in my class, only to have me show his slide. He's a health economist in Ontario, and did what I think is a really interesting study of primary care payment reform there from back in about 10 years ago, looking at an opt-in payment reform where primary care physicians could choose to be in a capitated model versus an extended fee-for-service that had a little bit of a case rate to it, but was largely fee-for-service. And he looks at who chooses what in terms of those contracts where it's voluntary. And you can see that the switchers and the stayers at baseline, that's 2006, they're different. And so maybe doctors don't know, they don't have all the data to know what their quality is, but they sort of know if they're going to do really well under a productivity contract, or maybe they'd be just as well having a capitation contract. And so the most productive doctors, and I use productive just in the sense of generating visits, not that those are necessarily good things, but the most productive doctors stay, and the least productive doctors switch. So it may be that the least productive doctors are actually really productive. They take long visits because they also do a lot of care coordination. They work on electric bills, all the other things that we were talking about today. But strictly speaking, from the point of view of what the government is paying for, the ones that stay are generating the highest fee-for-service bills, and the ones that switch were already cheaper. And so you can see there's, down below, it's probably too small for you to see, there's a big selection effect. If we just compared the cost at the end of the day between those in fee-for-service and those in capitation, we get the wrong impression, right? That the change in payment accounted for basically less than half of the total difference between the two groups. But this study, like many others in other countries, including the US, confirms that if you pay for volume, you get more volume. And shocking. And anyone with kids knows that this is true. And they were able to look at quality only at least in this paper, they only looked at the amount of time spent with patients. And they did find that the capitated docs are spending more time with patients. And so there may be a trade-off there that could be beneficial. Most of the fee-for-service capitation, fee-for-service salary data that we have, there's no good quality measures reported. And of the studies that are out there, at least in my last review, where we have a little bit of data, there's some on each side. But for sure, moving away from fee-for-service will reduce the volume of office visits, and that may free up, in the right system with the other right supports and accountability, that may free people up to do things that are beneficial that are not visits. And so, in terms of pay for performance, what we know largely comes from sort of quality-based pay for performance. You can, of course, put cost measures in pay for performance systems as well, but most of the pay for performance experiments around the world have been using evidence-based process measures, so things like beta blockers after heart attack, intermediate outcomes, and the system in England has quite a lot of these intermediate outcomes that I think we heard about before: blood pressure control, hemoglobin A1C control. Those are impossible for payers that rely on billing data to use, so you need access to either clinical registries or electronic medical records, as they do in the NHS. But also pay for participation in things like quality improvement activities or other non-billable activities. Mostly the literature in the US is actually, I would say, quite negative, but globally, there is now actually, which I think is quite an achievement, there is a review of reviews. I'm not sure if there will then be a review of reviews, but I think everybody wants pay for performance to work, so people keep doing literature reviews on it. And you can find some successes, and there are, and where there are successes, I think we can debate whether whether it's a success or not. And so since we have someone from England here, I won't step out too far, but the folks that I know who have worked on the quality outcomes framework in England and done the evaluations, Martin Rowland specifically, feel generally, yes, there were improvements demonstrated, but on that line of incremental cost effectiveness that we saw earlier, where the benefits are like this and the costs are like this, it seems to fall in that category. And his general belief is that it doesn't make sense to continue to invest in such systems, at least in the same way. And again, the U.S. results in part because we have this fragmented financing system. So when one payer does something, it's very hard to get a result because you're just one slice of the pie. But this is one of my favorite slides. This is a big evaluation of the U.S. hospital pilot that predated the hospital value-based purchasing system. And it worked so well, of course, we implemented it for everybody because we are nothing if not evidence-based. So the pay-for-performance hospitals in blue, this was a self-selected group. They chose to participate. They started off as higher performance. If you squint or you run a regression and you leave out the last couple of years, you can find a very small effect for some measures. But once you put in, the other years, you see the two groups basically come together. And again, this would, those early gains might be worth it if the expense of collecting the data and everything else that was undertaken to presumably improve quality, were not so great. So pay for performance, I have to say, it may have a role to play, but it's clearly not how you drive a system because there are too many things that we need to improve out there. And so moving away from that top-down model where the government decides what are the right measures and then pays for each of those to a model with stronger local accountability, I think is very much supported by the evidence. So really alternative payment models in the US context are attempts to do that, attempts to push down and delegate accountability to lower levels by way of global payment with quality measures around the boundaries. And I don't note in the slide, but there is some private sector evidence in the US that is slightly more favorable, I would say. There's a big payer where I live in Massachusetts that has implemented an ACO-like model with quality measures, and they find very substantial quality improvements. And they find, depending on how you look at it, neutral costs. The providers saved money, but because they got shared savings, that wiped out the savings to the payer. But quality improved, and there may have been other benefits. In the Medicare system, what we're beginning to learn about all of these new payment models is quite mixed. So there have been some successes in bundled payment, and which is very consistent with work from something like 25 years ago in cardiac care as well. The ACO results are quite mixed. There have been some systems, particularly those systems that, like Mayo, have a history of doing this kind of population-based work, not systems that suddenly said, we need to do this, let's form an ACO and go. There have been many systems that have not demonstrated savings, and overall, for Medicare, if you look across all ACOs, there seems to be no savings yet to the government. Likewise, we heard about team-based incentives before. There's this comprehensive primary care initiative, which is around a patient-centered medical home model, team-based care. The pilot used a shared savings arrangement, so we don't actually know whether any of those savings got down to non-physician team members, by the way. People talk about this a lot. I've never seen any data, and certainly the government's programs do not require that those incentives get down to the front line. But the Comprehensive Primary Care Initiative essentially found some improvement, but no savings, and they have since removed the shared savings element of that program. There will continue to be additional payments for the quality improvement work and quality-related incentives, but no shared savings. So, where did this leave us? It's pretty clear that the payment systems we have now often get in the way, and we, more than you, are really not getting enough value and look, I wrote value for money, sorry, Reinhardt. we're not getting enough value out of our healthcare system, and so we do know that paying for volume really shifts the focus of the whole delivery system on volume. And I think I don't usually think about payment systems as motivating clinicians, because I don't think clinicians need that motivation. But it does drive the delivery system. So come to Boston sometime and look really hard for the beautiful, tall, glass behavioral health building, and tell me when you find it. But I can show you a few for cardiac procedures. And so, what we pay for determines what the system sets itself up to do. Changing the payment system really have these big organizational effects. And then we need leadership and organizational strategies to make sure that the patients and the clinicians work together to achieve the outcomes. That's not going to come from the top down. We probably will always have a variety of payment systems, and even in a place that maybe is a little bit more homogeneous in terms of the delivery system, I'm sure you will find that it's necessary to pay some family practice docs differently than other family practice docs, the ones way out in the rural areas. That variety, I think, is consistent. But perhaps this evolution towards more accountability, towards more global payment, is one that makes sense to free up the resources that we think can be better allocated to improving patient health. But clearly, all of this requires a lot more than payment reform. So, thank you.